Hello everyone, today we will discuss about a case of minimally invasive spine surgery, fixation using the percutaneous instrumentation and tubular decompression. The minimally invasive spine surgery gives a tremendous advantage over the conventional open surgery, avoiding the morbidity related to the open surgery and early recovery and fast discharge. Patient was 56-year-old female with history of back pain, mechanical kind, with both low limb claudication and severe pain. Antalgic gait and SLRT being positive on examination. X-ray shows grade 1 enterolithoson flexion. MRI was showing multiple danger to disc with L4-5 severe canal and facetal hypertrophy, which was correlating clinically also. Otherwise, L1-2 and L3-4 canal stenosis were there, but not correlating clinically. Patient underwent bilateral L4-5 fixation using titanium pedicle percutaneous screw with interbody and autologous bones. Patient was in prone position on a Wilson frame. Initially, marking was done about 4 cm bilaterally from the midline, confirmed with the CM. Infiltration was done to avoid the unnecessary bleed. Initially, gemstone needles were used to locate the entry point and cannulate gradually. So initially superior were done at L4 and followed by L5. You can see here bilateral gemstone needle and catheter being placed in the upper level, and there was mild scoliosis causing severe left side foraminal stenosis. After the fixation of the catheters, we had done a tubular decompression. The facetal hypertrophy was so severe, so it was needing a facetal removal. Facetectomy was done under microscopy guidance. Gentle gradual chiseling was done to remove the inferior L4 lamina and adjacent facet, which gives adequate space also for the root and medially up to the midline. Ligament plane was also severely hypertrophied, which was causing canal stenosis. Bony hypertrophy and ligamental hypertrophy, as in any other canal stenosis, were the severe cause of the lumbar canal stenosis. After bony removal, we can see now we are targeting the removal of ligamentum flavum, releasing it medially and superiorly as done in the conventional microscopic decompression. As we will be approaching it from lateral with a tubular dilatation, unnecessary neurovascular damage to the posterior component of the spine are spared, which lead to the good result and early recovery, and morbidity related to the surgery like persistent back pain are very minimal. Now we started seeing the dural tube medially. Ligament was significantly hypertrophied, being removed from its attachment medially. Then it is excised gently from lateral aspect. Its thickness and adherence to the dural tube made peaceful removal little difficult. After removal medially and superiorly, it is being addressed at laterally above the root. Because of the severe long-term compression, the vascularity tend to be little more compared to the conventional disc flaps. Now we are addressing the lateral aspect of the bone and ligamentum together. It's always better to see the shoulder of the root and follow it downwards till the foramen, as I am doing it here after decompressing superiorly. Now we have removed significant part of almost all of ligamentum flavum on this side, and the root being checked. We can see the root going laterally outwards. For surgical orientation, Also we can see the vascularity is significant here, so being coagulated as and then whenever needed. After completion of the ligamental and bony decompression, discectomy is done on ipsilateral side, keeping the root safe with the root retractor. Once it is completed, end plate preparation was done for the further cage insertion. It is done using the curates and multiple raspers, which will help for the removal of the end plate disc. We are confirming the same. Cage size was confirmed using multiple level raspers again. We have used 9 mm height cage, which was being pushed under vision, microscopic vision, gently tapped to fit in the interbody space, and continuously root is being protected using the root retractor, so that we'll be confident it is not being pulled inside or the dural damage is being done sometimes because of the non-visibility of the structure. The oral corridor being the very narrow here, so that has been taken care. Once the cage has been inserted, it's better to confirm its location both mediolaterally and anteroposteriorly. Unnecessary slippage of the cage may cause neural structure compression. So after the cage insertion, completing the decompression by foramen anatomy, again we can see how the root is going from medial to lateral. Remaining ligament phlegm at that level is removed. Now we can see the collapse displace has increased the height, and all the 4 screws being placed one after the other. This is the first screw being placed under CM guidance. Continuous CM shooting is needed. The superior screw has been placed. All 4 screws are placed, and the cage is in upright position. AP shoot with the rod being placed. After the placement of the rod, the top screws are placed and confirmed. This is the minimum incision that we get. Immediately after surgery, patient was walking and very comfortable and happy. Being discharged in the second day, and she was diabetic, hypertensive, obese, and also old lady. So special thank to our doctors and anesthetic OT staff. Thank you.